Very interesting, very beautiful tumors, and you love it, love removing them because you have to deal with all the nerves and vessels down there. And we surgeons, until unless we do have adrenaline rushing in, we don't enjoy. So this is something about parapharyngeal tumors. So to the greater cornu of the hyoid, it comes like this, which is bounded laterally by the medial pterygoid and ramus of the mandible. Medially, you know that even the tonsil is there, your buccopharyngeal fascia and the superior constrictor muscle there, and it has been divided by two parts. Like radiologists per se, they take parapharyngeal tumor as the pre-styloid, but for us, it's divided by the styloid process and aponeurosis of sugar canal and testule, which forms a floor there, and making it a pre-styloid and the post-styloid. A pre-styloid one is a non-vascular tumor, that is a muscular space. The post-styloid one, which has got the carotid sheath and all those nerves and vessels and blood along. Most of the lesions, what you get. So if you go in a dissected specimen, this is right dissected. If you can make out, looks like a bit difficult one, but it is not. Maxillary tuberosity, buccinator muscle, medial to it would be a buccal mucosa itself. Okay, so just go laterally. This is our lateral pterygoid process. So from here, if you see the styloid process, it is coming like this. All three nerves, stylopharyngeus, glossus, stylohyoid. So this makes the whole diaphragm. So any lesion which is posterolateral to it is post-styloid, which has got all those vessels, and which is medial to it, which is the muscular space. And tensor valley palleti also makes its medial boundary there from here. So pathologies, you know, most of these tumors do have some salivary gland origin tumors, which could be either from the deep lobe or could be from the isolated or a de novo or accessory salivary gland tumors. Second one category is neurogenic tumor. Most of them are schwannomas, and third one is miscellaneous tumors, out of which you see carotid body paragangliomas, vagal paragangliomas, and other things. Salivary gland, I'll not go in details of this because this thing, Sampath has already taken a big account about there. I'll talk a bit about the carotid paragangliomas. You have already gone through the classification. Then Vishal Rao and Suprita Arya from Tata, Vishal from Bangalore, they came up with a modification in this Chamberlain's classification, because sometimes it was not like, if you see radiologically, clinically, sometimes it was not found as per radiology. So this angle 180 degree, they made it 270 degree, and along with the hypoglossal nerve, they made a different subclass with this. So jugular tympanic already taken. Vagal paragangliomas are something which are difficult one for me, because they are very vascular and they are more highly placed as compared to the carotid paragangliomas. Most of them, they are reaching till the jugular foramen, and sometimes even going through that, making a dumbbell, and they are very vascular on the surface. So there are more difficult tumors, but very well amenable to excision. You can very well do that. Schwannomas, we have talked. So these are investigation. What you want is, first is ultrasonography, preliminary investigations. I don't find much benefit out of ultrasonography. For me, battery of investigations is both CT and MR in my go. First get the radiology, then get an FNAC. If you are ordering an FNAC, suppose it is a carotid body tumor and the pathologist could not make out the pulsations and all, this could lead to a bit of hemorrhage and blushes there inside. So at first go ahead with the radiology, then think of getting a FNAC. What we do, what I have experienced is, 3 or 4 cases I had parapharyngeal space tumors, could not make out what is the pathology on imaging. We subjected them to FNA, turns out to be lymphoproliferative tumor. What do you do that? Do now? So what we devise a protocol for that. We are subjecting those lesions for ultrasonic guided true cut biopsies. So those true cut biopsies are getting me sufficient material to go for ISCs, immunohistochemistry, and then I make out whether it is lymphoma or something like that. Because if it is lymphoma, you are removing no use. If it is lymphoma, you know prior, subject them to chemo and job done. So this is something we are doing in addition to all these things. Radiology, all those things, CT, HR, CT temporal for parenchymas and MR neck. Differential diagnosis, you can make out if it is salivary gland tumor, on CT dystrophic calcification would be there, post-contrast enhancement would be seen. While in schwannomas, low to intermediate attenuation, intense contrast enhancement. While in CBT, you know, they are very well enhancing and splaying would be there, that is known as Lyris sign. So on MR, if you say high signal activity would be there with the salivary gland tumors, while with the parapharyngeal schwannomas, heterogeneous hyperintense tumors would be there. It depends on the presence of antennae type A or type B. If it's antennae type A is more there in the tumors, it's relatively low, otherwise relatively high intense, high signal activity is there. In obviously CBTs, you can make out that typical salt and pepper appearance due to those vascular voids there in the substance and brachial cysts and all those things. So you should know the first thing in radiology, what you know is, you should know the normal radiology and always try to see for this fat pad there in parapharyngeal space, because shift of this fat pad would tell you what sort of pathology you are dealing with. Suppose it is being shifted anteriorly, anterolaterally, that is something is there in the mucosal space. If it is being shifted anteromedially, something is there in the vascular space. It is being shifted posteriorly, it must be something from the salivary gland origin, because there is some aberrant salivary tissue or the deep lobe of parotid. So this is how Dr. Jatin P. Shah came with this figure. It is there with the Jatin P. Shah book, if you want to read further. So this shifting of this fat pad, if it is normal parapharyngeal fat pad, if it is being shifted mucosal lesion, shifted posterior-medially, vestibular space lesion, shifted like medially, anteriorly, parotid space lesion, and like anteriorly as such, like this, anteriorly, anterolaterally, could be a carotid tumor. Angiography, if you are thinking of carotid or some vascular tumor on radiology, you can go ahead with angiography or dynamic angiography. Parapharyngeal I will not deal. So most of the cases should be dealt with a surgery, except a few cases like in old cases, 65 years and more, already multiple cranial palsy is there, and the tumor growth is very slow as per the serial imaging on a few years. You don't have to deal, you don't have to touch those tumors. So this is how we decide surgical approaches. You have a lot of surgical approaches for pharyngeal tumor, right from per oral excision. These days, endoscopic excisions being done. Dr. Bharti MB, ma'am from Mysore, she is doing a few cases with the endoscopic approach per oral, making a small incision, at the two places, at there, one at the intermolar region and one in the buccal pad fat anteriorly, and going laterally along with the endoscopes, and she removes the tumor. So you can do that. That is doable. So there are transcervical approaches, cervico-parotid approaches, cervico-transpharyngeal with mandibular swing approaches. But believe me, I have seen people operating with the mandibular swing. Still, they use their finger there at the skull base. So what I have learned out of my 100 cases, 90 cases, at least 90 cases I have done with the transcervical approach.
Yeah.
And very well done. Yeah. Whichever size tumor is, wherever it is going, if it is going till the jugular foramen up there, you can remove that. I'll show you. And 7 cases I have done per oral, because if it is a very medial, superiorly placed, making an incision there in the soft palate, widening up, and you can take out the lesion. Because these are well-defined tumors, mostly. Well-capsulated, well-defined, you can take out. So this is something we have learned. Now, a new approach is coming, that is transoral robotic surgery. The advantage is you get a 3D image because it has got an incorporated camera along inside, and a delicate dissection, because the human factors, tremor, micro tremors which occur with human fingers do not occur there with the robot. So that is something which is beyond our expertise with the robot. And then better visual access to all those, even hypopharynx you can go along with the oropharynx, hypopharynx with the things. Just like cows, they do transoral ultrasonic guided surgeries. But the concern is vital structures which are there, sometimes you can't retract them, they come in the way, sometimes the injury can happen. And tumor spillage, because here when you open, the whole tumor is there in front of you. You can very well manage with your fingers or whatever instrument you want to use, but there you do have limited access there. If it ruptures, the spillage would be there, and that is something very dangerous for the patient. Indications, usually the gland, salivary gland tumors for robotics, schwannomas and others, Brinkel cell classes. Absolute contraindications, involvement of carotid, dumbbell which is going up there, vascular lesions, and involvement of skull base, because skull base, if it is involved, you can't use robot there. You have to drill, you have to do a lot of things there. So I'll not go in detail, but like carotid body tumor, patient's age is the major factor, along with the cranial nerve involvement. If it is young, single nerve involvement, surgery can be considered, but if multiple cranial nerves are at risk, better observe such cases. If growth is there, you can go for surgery or radiate, but irradiation, I have never sent a single case for radiation of parapharyngeal tumor. If it is stable, observe. But in old age, most of the time I observe more than 65 or 70 years age group. If it is growing, you can subject to radiation, but you can try surgery with a good consent. And now you do have a good multidisciplinary approach. You can do, you can deal with each and every case. Even in cancers, type stage 4 cancers, squamous cell cancer, carcinoma head neck, it was 4B was involvement of carotid, skull base or prevertebral muscles. Involvement of carotid does not make a contraindication now. I have seen Tata people operating on carotids also. They are resecting it along with the tumor and doing a Goritex bypass. So, and it has given preliminary good results in terms of survival as well. And if you talk about, so if it is a single, now if you talk about multiple, single MRI surgery, if it is multiple surgery for carotid body, you can think of observing vagal, then salvage surgery if required. If it is a bilateral one, surgery for the smaller size tumor first. You want to save the carotid from the smaller size because that is easier to do first. So you do first the smaller size tumor. Glomus vagal, I think we have talked. Vagal also small volume tumors, conservation surgery. But large volume tumors you have to think of. We have also published this using tumor marker with the parapharyngeal tumors. This is our protocol. I have already told, subjecting them to true cut biopsy. There are challenges. There would be complications, but with knowledge of anatomy, dissections, and well planning. So don't always go by the studies. A lot of studies would be pouring in each and every second there in the world literature. You have to go by your own experience and your colleagues. Sometimes you find motivation, sometimes motivation finds you and pushes you forward. Thank you so much.